I've come to know her work for the past few years. It's highly interesting work. She's leading, top-notch, state-of-the-art research, and as you can see from the title of the talk, too, very, very important and timely topic that she's working on. So we're very excited she's visiting us, and she accepted my invitation to be here. So thank you very much.
Okay, thank you for the invitation, and it's my pleasure to be here. So today we want to talk about lack of fairness in AI-based medical image diagnostic tools. So I'm starting with a true story of a friend of mine. Maya was a student. Unfortunately, she developed a medical condition which was affecting her ability to function, and initial assessment didn't show any diagnosis for her. Therefore, she sent home without further assessment. If you look at the literature, you can see the evidence of existing unfairness in healthcare and without using any AI. So even the real healthcare, we have race and sex biases. For example, there is a race bias in medical risk score analysis tool. And just to give you an intuition how important it is that, like, suppose that you are going to the hospital with some medical condition and they want to assess you if you are going to develop a heart attack or not. And they are giving you a risk score. And in the current risk score analysis tool, Black patient has to pass a higher bar compared to white patient to be considered as high risk. And these are the algorithms that we are already using in a healthcare system.
Can you ask questions during presentation?
Both are fine with me, yeah. So we are female are receiving longer time to diagnose compared to male patient, even if they are having similar medical conditions. Patients with similar condition are treated differently in hospitals based on the quality of their insurance type. And some pre-assumption regarding diseases. For example, we have some pre-assumption that maybe in some certain ages you are less likely to develop a specific cancer. So those type of assumptions, and sometimes they are not actually really true, they are affecting on underdiagnosing patients. And these are the biases that we have in real world, like without using AI. Now we are gathering this bias data, we are feeding them to AI algorithms, and we want to build algorithms to use them in practice in hospital. And what we are worried about is about the fairness of these algorithms when the data itself is already biased. So in this part, we are talking about if AI diagnostic tools are fair or not. And we will going to define what do we mean by fairness, and also we are showing to you the fairness analysis of AI model in medical image diagnostic tools. So let's see. For example, when you want to train an AI model, the standard approach is to collect some data and train your AI model to reach some diagnostic labels. And the standard practice is to train this AI model on overall population. However, the overall population is a mix of people from different ages, different races, different sexes, and also different social economic status. So in this context, like whenever I'm using insurance, it's a kind of representative of social economic status of the patient, because patients with medical insurance, they are often in lower income. And as you can see, like these data sets are extremely skewed toward different subpopulations. So we want to ensure that these AI models that we are training are providing fair outcomes, regardless of what is the membership of this patient, which groups they are belonging. So what do I mean by fairness of AI model? So there are many ways that you can define the fairness of your AI model, and typically, we are asking from knowledge experts that what do they care more, and what with respect to what quantity, what metric they want to provide some fairness. For example, in equal opportunity of fairness, which is one of the fairness metrics, we are trying to equalize true positive rates, correct disease diagnosis, for example, for different patients from different sexes, ages, races, and so on. And it's actually really problem-dependent definition. So at this talk, as I told you, I'm gonna talk about some bias characteristics. We want to understand bias and fairness properly. So I'm starting with some common misunderstanding of the fairness, and then we will dig into that more. So the first one is that if you have a lot of data, or if you don't have even a lot of data, if you are building complex models, we can train an AI model with a high performance, and if we do that, then we can deploy these models in practice, and the model is good because it has a high performance. So we trained AI model in the context of X-ray domain. We wanted to do pathology detection on 14 labels that we had in public X-ray datasets. So in X-ray, we have a luxury of having access to multiple large datasets. So MimicTX are gathered from PhysioNet at MIT. It has over 200,000 number of images. Shakespeare has more than 200,000 number of images gathered in Stanford, and NIH dataset has about more than 100,000 number of images. We also even aggregate all these three datasets on shared label and build a dataset of 700,000 number of images. So we have a huge number of data, and we are expecting that our model could learn properly. And this is a luxury that we have in just X-ray domain. I know that in many other fields, we don't have even luxury of having that large annotated data to be able to train such huge models. We did that. We tried to train good AI models, and the state-of-the-art performance average across all 14 labels that we had in this data set, and we reached very high performance. So that's the point that usually the researchers stop. They are saying, okay, we have a good model, high performance, and they are publishing a paper, or they are thinking about the next phase of their research. What we did was that we were stopping at this point. We say, okay, maybe it's not a good point to stop. Maybe we need to do fairness evaluation and see how does the performance of model is changing in different subpopulation that we have in our data. For example, here we focus on no finding label, and in particular false positive rate in no finding label. Why we like that? Because false positive rate on no finding label means that the patient has a disease, but the classifier predicts that the patient is healthy. So the patient will not receive the treatment in a timely manner. So we wanted to see how does this underdiagnosis rate varies in different subpopulations that we have in our data set. So for example, here you can see underdiagnosis rate across different sexes, different ages, different people with different races, and different insurance types. For training these models, we just feed them X-rays, nothing else. And you can see that female, young patients, Black or Hispanic patients, and patients with Medicaid insurance who are often low income, these people who are actually from historically underserved subpopulation in society, they are having higher underdiagnosis rate compared to, let's say, male patient or white patient or people with private insurance. So it seems that these models reflecting the biases that we have in society. We look into the intersectional identity, and we realize that if a patient belongs to more than one historically underserved subpopulation, again, this bias will be amplified. For example, Hispanic female have higher underdiagnosis rate compared to white female. So not all female are the same. Like it depends on which age they are or what's their social economic status. This value is gonna be changed. And if you are belonging to more than one historically underserved subpopulation, you are at a very higher risk of being underdiagnosed. So if you are using more data or building complex model, it's not enough to ensure that your model is properly good, and it's time to deploy that model in practice, because they may suffer from unfairness. Another common misunderstanding is that higher underdiagnosis rate could rate from overall noises. So people coming to me, okay, you are making it so big, so a little bit underdiagnosis rate is higher than in one population. It doesn't mean that there's a systematic bias. Maybe it's a noise in the system. And the reality is that noise creates false outcome in whole system, and it's like for example, you randomly has kind of increase of false outcome in your system if it's a noise. So it shouldn't be distributed like in a systematic way in different subpopulations. So we evaluated the overdiagnosis rate, and we realized that underserved subpopulation are being flagged wrongly healthy without corresponding increase of wrongly diagnosed of disease in the algorithm. So if you are if the females are underdiagnosed at a higher rate, they are not overdiagnosed as well. So there is this reverse kind of relationship between these two concepts. But if it was a random noise, there's like you shouldn't see any kind of pattern between these two quantities. So higher underdiagnosis rates are not overall noise in the system, and they are something that we really need to care about it. Another thing that I hear a lot is that when people see that I'm working on fairness, especially like the hospitals, they are saying, okay, we don't have any stakes on fairness. We are sure we have developed a very good data set. We have equal proportion of male and female in our data set to be fair. So we are good. So don't be worried about our case. Let's see if that provides fairness or not. Our study has shown that there is not often a statistically significant linear correlation between subgroup disease membership, the percentage of patients that have a specific disease, and correct disease diagnosis on fairness. So if there is therefore, just if you are equalizing the number of, for example, female and male per data set, the number of patients that you have with positive outcome in the data set, it doesn't make your model fair. We can see see other patterns as well that may be kind of justifying the same problem. For example, the lactation, they are second largest subgroups in our data set. So for example, in the data set that I was working, 60% were white, around 17 patients were black, and the rest of them were even a smaller group. For example, Asian, they were the most minority group. Just only 3% of the data set were Asian. But when you are plotting the unfairness and evaluating the unfairness, you see that Asians are like maybe the second best group, like close to white patients. So though they are really minority in your data set. We also observed same pattern of race bias in another data set that was gathered in Emory Hospital. And an interesting thing about Emory data set is that it has 50% black and 50% of white patients. So like they are located in a location that like naturally there were enough black patients. And even same patterns that we can see in mimic CXR data set that was gathered in Boston, we can see similar patterns of biases in that data set as well. So it's not really about the percentage of patients that we have. So equalizing the proportion of patients from different subpopulations in the data set doesn't provide fairness automatically, and it's not always even feasible. Like you have many sensitive attributes. It's not just about race. It's not just about sex. You have like social economic status. You have many other factors, and you cannot really make a data set that's equally distributed among all of these factors. The other thing that I'm hearing is that people are saying that we don't have race unfairness because we haven't included race data in our AI model training. So my models don't know what's the race of the patient, so I'm fair. And it reminds me the Canadian healthcare system, because in Canadian healthcare system, we are not allowed to gather race information of the patient. So, and just to be fair, and let's see if that approach provides fairness or not. After we published our results of underdiagnosis rate that I just show you in Nature Medicine, I was lucky that the message of our paper was heard by the people that I really wanted to hear that message, and they were the institutes that they were gathering data sets. So I was contacted with a group of researchers from Emory University, where they are gathering large X-ray images from field unit at MIT, and they were also having the MIMIC-6R dataset, which is the largest X-ray dataset that we have. And later we have also collaborators from Stanford University that they have the second largest X-ray dataset. And we built a group to realize that why this problem is happening. Why do we have lack of unfairness in the data sets that they have gathered? What they were telling us was that they were all physicians. They were saying, okay, radiologists don't see the patient. When they are doing all the annotation, when they are reading the images, they are sitting in a dark room, they haven't seen the patient at all. How can a doctor be unfair to the patient that he has never seen? Like, how do you say that they are unfair, and why their outcomes could be unfair? So that was a valid question, and we were asking, okay, it seems that doctors don't know the race of the patient. What about AI? Can AI see the race of the patient by looking at medical images? So it was a large group, and we have access to a lot of data sets because they were from three major kind of data gathering centers. And we tried to do race detection from medical images. So our results was very surprising because among different medical imaging modalities and on data sets that they were gathered in different locations, like in US, we could see consistently that AI was able to detect the race of the patient with a very high performance, mostly over 90% performance. We were able to find the race of the patient by just looking at medical images, nothing else. And it was very surprising. As I told you, half of our team were clinical people, and half of us were computer scientists. And I can imagine that if we were just computer scientists, maybe we didn't realize that how important it is. But for clinicians, it was very important. They say, okay, that's surprising because we are not really able to see the race of people from looking at their medical images. So the next question was that why and how AI can do the race detection. So we tried to do a lot of applying a lot of explainability techniques to try to realize how AI can do race detection from medical images. So for example, we thought, okay, maybe it's the race informations are located, for example, in organ, like does it located in organ, or it's on the whole image, or in some specific part of the image. For example, here we subtract, let's say, the lung region and use all this type of image that they are only having lung for feeding to the AI model to do the race detection, and still we have a high performance in race detection. Then we remove the lung and we get the rest of the image. You can see a still high performance, higher even compared to the lung. And also you can see the results for original images. So it seems that the race information is kind of everywhere, though it seems that it is less in lung region. Another approach we took was that we kind of divided images to a number of patches. And we remove one patch at each time and use the rest of the patch for race detection. And again, you can see very high performance at race detection. Then we were using just single patch to do the race detection. And in the single patch case, we can see just this one, the one that's belonging to this patch, has less race information, but from the other patches, still you can have a high information of the race of the patient. So I remember that every week we were gathering and we were thinking of a way to kind of figure out how we can do race detection from medical images. We tried many things. Maybe this is the patient BMI that play a co-founder here. Maybe it's the patient bone density. Maybe it's the tissue density in case of mammogram. Maybe it's imaging equipment or the hospital that the image has been taken. Maybe it's the prior disease that's causing these conditions. Maybe it's age or sex of the patient, or age, sex, disease, and all the factors. So we tried anything that came to our mind, and longest story short, none of them were contributing in race detection. So we come to the point that we said, okay, we need to find out how and what condition we can break the situation. No matter if our study doesn't mean anything, we want to find a point that AI couldn't do the race detection. So we try to, for example, reduce the resolutions of images to find a point that AI cannot do the race detection. And you can see, for example, even by 8080 resolution, something around here, still we have over 90% kind of race detection capability. So we reduced it even to 4x4 images resolution or 8x8 resolution. And like, surprisingly, like even if you just give it this black box of nothing, almost nothing meaningful for radiologists, it was possible to do the race detection. And you're laughing, and we were just feeling crazy in our meetings because anything that comes to our mind next week, the answer was that no, I'm not doing that based on that. So again, another crazy stuff. So we try to pass the images through low pass filter and high pass filter to see at some point when we cannot do the race detection. Still, like you see, like for example, for low pass filter, when we have such an image for training the AI model, with around like 75%, you can do the race detection. Or even if you give like this completely gray image that no X-ray is visible inside it, you can do the race detection with a high performance. So it seems that race information is something like a fingerprint or something really embedded in the image. Like no matter what you are doing, it's visible for the machine, though it's not visible at all for humans. So another study, like I usually stop at this point, so I'm left the audience with like shock that, oh, what's the mystery is here. So another recent study that we just published in 2024, we try to kind of localize racial information. So we said, okay, let's give the average white sample, like all the white people with no finding labels, the healthy images. You should get average of the X-rays of them and do the same thing for black patients and subtract white samples minus black samples, you get something like this image. So it seems that like in some areas like this, they are actually different, but in these areas that they are blue, they are kind of the same. So it seems that the average black X-ray is kind of different with black white samples. And we applied some saliency map technique to try to localize the location of where the model is looking when do the race detection. And we find that like if you apply different methods of saliency map, you get different results. So they are not generating exactly same saliency map. But if you're looking at different techniques, you see that, for example, for black patient, it usually look at this center part. And for white patient, it look at in this kind of two zones, they are more contributing in race detection. So it seems that there are some differences that, like, at least machine look at different locations for black and white patients. Yeah. So if you are not including demographic features such as race, you are not imposing fairness in your AI model. So another topic that, like when we were working on all of these fairness studies, like Google was working on developing X-ray foundation models. And it was interesting because they were trying to train AI models first on more than 300 million natural images, and it's much less than like ImageNet that's public to everyone. And then they were fine-tuning these foundation models on 800,000 X-ray images, and they were building these networks for simple finding, no finding, like if it's normal or abnormal. And the purpose of developing all these models was to come up with a foundation model that can learn good representation so that you can adapt it easily to different tasks. And an interesting outcome of this this model was that we were able, like, two other data sets were released, which was vector embedding of same data set that we were using. So mimic-CXR vector embedding is right now existing, and Checksberg vector embedding existed. And what is this vector embedding? The vector embedding is that, like, they gave images to that foundation model, and it generates a vector representation of this image, which is a smaller vector, 134 length, and you can easily kind of train an AI model using that. And you can imagine that it will be much, much, much faster. You don't need to use any GPU, and you can just put a simple head with two fully connected layers and do medical image classification. So it sounds very interesting because it was providing a lot of features which were looking very interesting. So we didn't have to deal with images anymore, and it was simple model training on simple CPU in your laptop, and it was quite interesting. So when we learned about these foundation models and the vector embedding data sets that they were providing, we were wondering maybe if we are using vector embedding representation of images for model training instead of using the original images, we may be able to remove sensitive information such as race. So maybe there are less race because we don't have the image anymore. So we try to conduct a study to realize first if vector embeddings are suitable substitute for medical images in general, and second, how would their impact using them would impact on the fairness of the AI model. So we trained AI model on vector embedding of mimic-CXR dataset, Checksberg dataset, and the aggregation of mimic-CXR and Checksberg dataset. For mimic-CXR, for all these three setups, the average in performance across all labels was improved. So if you were using if you were using vector embedding, you were able to get higher performance, though you have trained your model only on vector representation of the images, no image at all. And surprisingly, for some datasets such as Checksberg dataset or the combination of these two datasets, you can see that the performance significantly improved. Like instead of 0.8, you are getting 0.9 right now, which was very interesting. And I should say that all of this training was happening in 10 minutes rather than 1 or 2 days, which was very good for the students and also for us because we don't have to spend on GPUs anymore. So we did that, and next step for sure we did fairness analysis, and I liked a lot our fairness analysis on our first data set Checksberg. You can see like the gray one are the results that they were based on images. The color one are based on vector embedding. First of all the vector embedding results, the underdiagnosis rate is lower, which is good. So it seems that we have less underdiagnosis. And second thing, like you can see, they are more aligned, like along the line, kind of. So the gap between the best group and worst group has been reduced. So which means again the model is more fair. So it's fairer, and also the performance is like there is less underdiagnosis.
The colored ones are the ones for the new
vector
base.
Yeah.
So the spatial information was the reason that you are not fair, or not, because in your new representation you don't have enough spatial information. So maybe those.
The question is
it
why?
might be.
So why?
Yeah.
You're gonna analyze.
So always don't ask why because it doesn't end up something. But yeah, I'm joking. Like the reality is that we need to go for all this why. The next one was the aggregation data set. Like again, sorry about not aggregation, but again, if you are just looking at intersections, you see again dramatically like less underdiagnosis and also more align, which was very good. So I don't I don't want to hide as a supervisor. I was so excited when I see this image because it was fantastic. We have more fair model, more accurate model, and also like everything was looking very well. And in the all data set, mimic CXR plus CheckSpurt, similar thing was happening, which was great. But when it comes to the mimic CXR data set, it didn't happen. So in mimic CXR data set, we just for age, I could say a little bit the vector embeddings were less, and then like there was not improvement in fairness. So yeah, so these are the results that you don't want to see what it happens in reality. So the next question was that what's happening for mimic CXR data set? Why it is good on CheckSpurt, what is not good on mimic CXR? One analysis that we did was that trying to see how can we do race detection from vector embedding on each of these data sets. So if you do race detection from vector embeddings on images, like the results were over 93, 97, whatever, for vector embeddings, the result is still high, but a little bit less than images. But when it comes to CheckSpurt, you see that the result was still you see the race signal and it's a strong signal, but the race information are much less. So it seems that the blinder the vector representation to the race, the fairer they could be. Like even the performance was much higher, like when we were using vector embedding. So it seems that like in the process of coming up with those representation in mimic CXR, we end up with less race signal compared to CheckSpurt data set.
With more race. In the mimic CXR,
it was more race.
More race, which results in poorer or less fair.
Less fairness, yeah. But in CheckSpurt, we have higher performance, more higher performance in vector embedding for classification, much more better fairness when we have less race information, which was interesting, yeah. So race detection from vector embedding is still possible, but interestingly, the blinder the representation to the race, the further the output model. So how much time do I have? What time is it?
It's 4:49.
Okay. So I just very briefly talk about potential paths that we can go. For example, when we having this potential problem of fairness, so one way that we can approach is to find the cause of this unfairness. So for example, how does the patient get to the data set? Is there any selection bias in generating this data set? What's the role of variability in human judgment when they are labeling these images? What's the role of labeling techniques that they are, let's say, based on AI, on the outcome of this unfairness that we have? So these are potential root causes that if we go and investigate them, it may turn out to better AI models regarding the fairness. We also, even if we couldn't find the root causes, maybe we can try to algorithmically do the biasing. For example, by doing pre-processing stuff, for example, oversampling minorities or undersampling majorities, or debiasing through model training, working on loss functions or regularization to improve the performance for some groups compared to the other groups. Or we may do full cycle analysis and try to find different thresholds for defining positive and negative for different subpopulations. But all of these techniques require us to know the patient membership. We need to know like if the patient is Black or white. And the reality is that it's not always easy to have access to those information. And even this, for example, we have people with multiracial. So which category you want to assign them? Or even like these topics are sometimes socially construct. Within the same family, let's say, immigrant to US, if you ask the father what's your race, the answer of the father might be different to the teenager boy that they have in the house. So it's not just relying on the self-reported race may not help for coming up with these labels and then being able to use these labels for debiasing of AI models.
In the previous slide, you mentioned that you can oversample minority, but then in more previous slides, you mentioned that that's not a reason.
So this oversampling and undersampling, they have shown that they are working when on natural image data sets, that they are biased. On image data sets, we can investigate them anyway. Like we can see if we increase, is it gonna help or not at the end. But in general, there is not a linear correlation between these two quantities. But they might be non-linear correlation. So not being a linear correlation doesn't mean there is no correlation at the same time. So maybe we can think of building techniques that they are giving us fair data sets. So usually we just use the data that we have. Maybe we need to invest on coming up with algorithms that they give us fair data and fair data sets so that we train our model to reach to the fair outcome. Also, like our results shows that if you are using multi-source data set, it usually provides more fairness. So maybe we can think of having different techniques to facilitate multi-source training, such as federated learning, so that hospitals willing to share their data or like not data, I mean contribute in even like in federated learning settings. So we can also look at the problem from regulatory and policy perspective. What fairness metrics are suited for different use cases, for example? What groups of patients should get to the data set? So what are the exclusion criteria? What should be inclusion criteria? What data do we need to gather from patients? For example, we have the example of race data, which is not allowed to be gathered in Canada. And the outcome is that I cannot do all of this study in Canadian data. I have to go and work on US data. What attributes need to be even considered? Like, it's not always just about the patient's sex and race. There might be many other factors that they are contributing in disparate outcomes for different patients, and we need to kind of analyze them. So, in summary, we showed that AI models not only can detect the patient race from medical images, but they also behave against historically underserved patients. And you can imagine that if you publish results with this outcome, like there would be a lot of, I couldn't say like interest or like frightened from the community. People are asking, okay, so what's going on? Like, if this AI is gonna detect our race, what would be the impact? Are there races? Like, what would be the impact on our outcome? And that's why we had a lot of like media coverage on almost in any single paper that I presented, so kind of published in this area. So in short, I could say that like when you want to, as we are working on developing cool AI models and doing all of this work, we kind of at the same time we need to think of auditing for fairness of these models before deploying these models in practice. And that's it.